Please join me to welcome Dr. Joel Tarikas. He is our cross-cutting medical director for the Bureau of Infectious Diseases Services and also the Bureau of Immunization Services at the Arizona Health Department Services. He is an internal medicine and infectious disease specialist. Dr. Tarikas received his medical training for both internal medicines and infectious diseases at the University of Arizona in Tucson. And also, Dr. Tariq has had the unique opportunity to obtain additional medical training at MD Anderson in Houston for the infections of the immunocompromised host, and the National Jewish Healthcare in Denver for the mycobacterial and respiratory infections. Dr. Tariq also holds a certification in infection control and hospital epidemiology, CIC, and advanced leadership in infection control. Dr. Tariqa served as our medical director, at the medical director for transmissional diseases and tuberculosis control officer for Coconino County from 2015 to 2023 prior to joining ADHS. Dr. Tariqa has collaborated with the CDC as subject matter expert and guest editor for the development of guidelines for management of bioterrorism agents. And last but not least, Dr. Tariq had graduated from the Safety, Quality, Informatics, and Leadership program at the Harvard Medical School in May of 2023. And then, Dr. Tariq, the floor is yours. Thank you.
Hey, thank you everyone for joining me. It is obviously an absolute pleasure to be here and chat with you about some of the topics that I'm more familiar with. And for the past several years, 12, 13 years, a big focus of what I have done in my career has been infection prevention. So infection prevention, antimicrobial stewardship, building up programs, making programs stronger. That is what I like to do. So I am very happy to see that a lot of people are also interested in the same things that I am interested. An additional housekeeping item, if I start talking funny, is because my mouth gets dry so quickly. So I'm going to be drinking water every so often. So thank you for living through my weird Donald Duck voice that is going to happen at some point. So basically what I want to talk about is blood culture stewardship and what the real impact is to our antimicrobial stewardship programs. As you may imagine, and some of you guys may be familiar with this type of an impact, because we are basically being measured all the time. We're being looked at very closely from CMS or some of our accreditation bodies regarding how many episodes of healthcare-associated infection we're causing on our patients. So that is basically what I'm going to focus on, that impact of prevention of bloodstream infections, as well as the impact to antimicrobial stewardship. I have nothing to disclose. I'm not getting paid, no financial relationships or gains, sadly. But it is my pleasure to be here. So why is, and I'm just going to dig very superficially on all the structure and small details regarding antimicrobial stewardship. Why is antimicrobial stewardship important? Obviously, as you may imagine, our main goal is to improve our antimicrobial prescribing practices. We want to make sure that we have a very good hold of how our providers are prescribing those antibiotics. And this is not a matter of us trying to be controlling with providers at all. We just want to make sure that we minimize the risk for our patients. We want to have the biggest bang for our buck, because by us having a good understanding and control of those prescribing practices, we will positively impact the multi-drug resistant rates of certain organisms or bacteria in the community. We will impact definitely the side effect frequency of some of the broader spectrum antibiotics, decrease the risk of complications such as C. diff, as well as decreased length of stay, as well as healthcare costs overall, because some of the antibiotics, especially broader spectrum, they are not cheap. So we want to be very, very much mindful of that. So when I say that we're being monitored closely, as you may know, Centers of Medicare and Medicaid Services, CMS, They want to make sure that we are optimizing the medical care. They want to make sure that we are working in advantage of our patients. They want to make sure that we are looking into the highest quality of care. So they have implemented, and this is not something new, they have implemented this hospital-acquired condition reduction program, which basically means that we're being monitored on how many healthcare-associated conditions our hospital or healthcare system is causing to our patients. What is the impact? Obviously, if we're seeing more healthcare-associated infections, we're going to get a decreased reimbursement, decreased payment to hospitals based on performance. How do they do that? They keep an eye on that. They monitor closely. They monitor closely for the number of healthcare-associated infections. And if we are at the top 25% of hospitals that are causing this type of an infection, we're going to have a 2-3% reduction in reimbursement, which happens to be a big problem once we're looking at big numbers of or big amounts of money. So when it comes to hospital-acquired infections, we're looking at several different HAIs. So we are looking at C. diff, we're looking at CLABSI or central line-associated bloodstream infection, which is going to be the focus of what we're going to be talking about. Also, catheter-associated UTIs, hospital-acquired MRSA, as well as surgical site infections. So what is the impact? What happens whenever we're dealing with this type of condition? We know that hospital-acquired conditions are not cheap. We know that whenever we're causing any one of those infections, that's going to require someone paying for the treatment or the management of that. And that someone will be your healthcare system. So what is the most expensive healthcare-associated condition? There's a couple: ventilator-associated pneumonia, center line-associated bloodstream infections, most of which, in average, will be somewhere between $40,000 and $50,000 per event. So that is a big problem that is causing a lot of stress around healthcare facilities. But again, this is not about the money. This is about our patients. This is about patient care. So if we look at excess mortality associated with these hospital-acquired conditions, basically, similarly to the cost, central line-associated bloodstream infections and ventilator-associated pneumonia happen to be the two conditions that can increase the risk of mortality. So basically, with this, we're looking at an estimate of excess mortality, which basically means the difference between the probability of death among those who have a healthcare-associated condition compared to those who do not have a healthcare-associated condition. Basically, what we're looking at here is that for central line-associated bloodstream infection, there is 0.5 excess death per case of bloodstream infection. So the impact to our patients, the mortality associated with central line-associated bloodstream infections, is quite high. So how do we stop this? How do we analyze this big problem? So we have to dig very deep and look at the root of the problem. So I'm not saying that drawing blood cultures is a bad thing, because there's going to be certain indications for us to draw some blood cultures. But as you may imagine, this could definitely be abused sometimes. And some of you guys are nurses. Some of you guys worked in the intensive care unit at some point. You may call your resident, or you may call your physician in the middle of the night, hey, your patient's having a fever. And instead of seeing your provider come in and do a bedside assessment, they will just tell you, let's just go ahead and pan culture the patient. So that is not the best of practices, because that will open a whole can of worms that could potentially have more complications and may not even solve a problem, but just increase costs, risks, etc. So whenever we're dealing with blood cultures, there is something that I call the blood culture cycle that usually starts by the initial intake when the patient comes into the hospital. And that is when the nurse gets to know the patient, gets the initial history, records vital signs. That's the initial intake. Then provider will come in, physician, nurse practitioner will do a clinical evaluation. And depending on what we're thinking, orders will be placed. Once blood cultures are drawn, once orders are placed, there's some diagnostics that will be run at the lab, and then results will be provided. So what is the impact? What happens when we get a central line associated bloodstream infection? What is a central line bloodstream infection? How do we define it? So basically, once we place a central line, if the central line has been in place for more than a couple of days, and if someone happens to order a blood culture, and that blood culture happens to be positive, immediately that will count against your healthcare system, against your hospital. So you may say, if you are a clinician, but that does not really mean that the patient has an infection. It could just be a contaminant. And I agree. I think that the criteria is not perfect. I actually think it kind of sucks. But that is what we have to go with. So this is how we're being measured. If someone has a positive blood culture with on someone that has a central line for more than 2 days, that will count as a central line associated bloodstream infection. So where does this happen? It can happen in the intensive care unit because there's frequent insertion of multiple catheters. Some of those catheters may be placed in emergency settings. There's frequent access, cleaning, moving around of the patient. Some of those catheters may be old. So there is a high risk of getting a positive blood culture. But believe it or not, the majority of the cases of central line bloodstream infections happen in non-ICU patients. Why is this? Because usually nurses that are in the medical floor, not in the ICU, they may be less experienced at managing these central lines. So that is a big concern, and most patients will be at risk for a positive blood culture. This obviously goes hand by hand with increased cost, and most importantly, and the reason why we're here, this will go hand by hand with an increase in antibiotic use. Are these antibiotics necessary? More than likely, they're not. Obviously, we have to be very cautious of how we interpret that clinical information to make sure that we make the right decision for our patients. When it comes to what type of bacteria cause central line associated infections, as you may imagine, by far, the most common organisms are bacteria coming from the skin. So if you say, hey, Joel, so based on the coagulase negative staphylococcus that we found in the blood cultures, do you think that this is a contaminant? I don't know. This is not a yes or no question. This is more of we need a clinical assessment to decide. So in order for us to stop this problem, I think that the best approach would be to really have that big clinical assessment before ordering those blood cultures, instead of doing that after the fact. So bacteria coming from the skin, by far, the most common type of organisms associated with central line bloodstream infections. Which patients are at risk? Many patients, especially those that have a catheter for many, many days. Those that have heavy microbial colonization at the insertion site. If your patient comes in with a femoral central line that was placed in the field, someone that might be an uncontrolled diabetic with a BMI of like 95, someone that has a lot of risk for colonization in the femoral area, those are the patients that will be at higher risk for infection. So there's many opportunities for improvement in that process. Obviously, as we're looking at a patient, we have to keep in mind a broad differential diagnosis. Someone that is in the ICU that has a fever does not mean that they have a central line infection, does not mean that we need to order blood cultures. We need to consider that there are rapid diagnostic testing that are available to kind of figure out if for whatever reason we order those blood cultures, and if they're positive, to try and figure out what type of bacteria we're dealing with. We have the local or our local antibiogram that will help us try to choose the most narrow antibiotic agent depending on the diagnostic testing that we have. We want to make sure that we work on an order sets, making sure that we manipulate the type of antibiotics that can be ordered for the condition, and obviously utilizing specialty services, clinical pharmacy support, infectious disease consultations. We have to rely on those experts. How do we become successful at handling a big problem of central line associated infections or any of the HAIs? We need to work as a team. So we need to have a sponsor. We need to have incorporate of chief nursing officers, medical directors, clinical managers, but most importantly, have our team that will support with implementation of any intervention to prevent HAIs. Those interventions should be impactful, easy to implement, inexpensive, long-lasting, something that is hardwired to the process, to the system, something that can be measured, and something that can be reassessed or modified if needed. So when it comes to blood culture stewardship, interventions are not difficult. Those interventions should not be expensive, should not be very hard to implement. There was this one interesting study that basically looked at a very simple intervention that was basically providing education and some degree of blood culture restriction to several units, several medical and ICU units in a hospital system. Basically, those interventions, the main goals were to measure blood culture utilization, blood culture positivity, days of therapy, and length of therapy. Surprisingly, and believe it or not, a simple intervention, a very simple intervention such as a phone call, asking for additional information from those providers of reasoning behind blood culture orders, asking if other conditions had been ruled out. That very simple intervention significantly decreased the blood culture utilization rate. There was obviously no difference in blood culture positivity, but days of antibiotic therapy and length of therapy for antibiotics both significantly decreased. So this is just a small piece of proof that a very small, inexpensive intervention can potentially have a big impact to the care of our patients. So going back to that blood culture cycle, we're going to start thinking about how can we impact the way that we order blood cultures. There are many areas in that cycle that we can impact to make sure that we optimize our antibiotic use by stopping inappropriate orders of blood cultures. Sorry, water is important. Starting with our nursing staff. So nursing staff in the emergency department, extremely important, if not the most important individuals caring for the patients. They are at the bedside. They tend to listen to the patients even more than the doctors. They advocate for the patients. So extremely, extremely important for them to be a part of this team to prevent inappropriate use of blood cultures as well as inappropriate use of antibiotics. So what is it? What type of help do we need from them? They're usually the ones to identify those patients that come in with sepsis. They're usually the ones that look at the chief complaint of the patient. They document allergies. This will definitely impact our antibiotic choice. They look at vital signs. They are the ones to let the doctor know, hey, this patient has a really high fever, hypotension, and they provide that bedside care, including line care, sometimes looking at the central lines that patients come in with, etc. So very, very important role. One of the main problems that I have seen historically is with our use of different electronic medical records, sometimes, depending on the patient's age, we may see that certain temperatures may be highlighted in red, especially when we're dealing with pediatric patients or when we're measuring temperatures through Foley catheters. Those triggers for fever may be different and they might be highlighted in red. So having a temperature measured or highlighted in the EMR does not mean really that the patient has a fever. So we need to start from the beginning. We need to understand what the definition of a fever is. Looking at different guidelines, especially looking at the neutropenic patient guidelines from the IDSA, that's the one metric or the one definition that I like the most. Fever in neutropenic patients is defined as a single oral temperature of 38.3 degrees or a temperature of 38 degrees that has been sustained for a 1 hour period. So that is one of the frequent questions that I get asked from a lot of our providers and quality nurses. They ask, hey, so what is our definition of a fever? When do we know that we have to call our providers? When do we know that we need to actually order blood cultures? So my usual answer is not a number, but my usual answer will be, it really depends on the clinical assessment. We cannot trigger orders for blood cultures, urine cultures, or you name it, without someone actually looking at the patient. So that is something important to remember, not only knowing those basic definitions, but also really, really understanding that a full clinical assessment is important, because fevers are not only related to infection. You can see fevers associated with drug fevers, with medication reactions, with other causes, maybe autoimmune. So that bedside assessment is so extremely important. Another big role that the nursing staff has in their hands that is extremely important is that line care and close monitoring of the appearance of the line. This study is something that was, at least to me, extremely interesting, because you may remember that there was something called COVID-19 at some point that we all struggled with. This study was performed basically measuring at rates of healthcare-associated infections during COVID-19, looking at the association between COVID-19 and a surge of healthcare-associated infections. So it is not surprising to see that rates of central line bloodstream infections, catheter-associated urinary tract infections, and MRSA bacteremia went up as we started seeing an increased number of COVID patients. Why is that? Because obviously patient encounters, close bedside encounters, even by nursing, that went down. Like, we were not going into patients' rooms. We remember having those pumps and stands with all of those IVs outside of the room. So we were trying to not necessarily be by the side of the patient at all times because of multiple reasons. So based on that decrease in bedside care from nursing staff, there was a 60% more CLABSI that was seen, 43% more CODI, 44% more MRSA bacteremia. This just shows how important it is for that nursing staff to be aware of those central lines to prevent that trigger of let's order some blood cultures, which will complicate the whole scenario by us physicians saying, let's just order vancomycin and Zosyn, which is all that we do. So make sure that you keep that in mind. Interestingly enough, just to prove the point, our rates of C. diff went significantly down with this in this particular study, which also proves the point that decreasing that patient contact also decreased C. diff, because we were not jumping from one patient to another. Okay, so going back to that blood culture cycle, what happens next after that initial intake, after that nursing care? We have that clinical evaluation, that clinical assessment from physicians, history and physical, early sepsis interventions, initial lab orders, including blood cultures if needed, imaging studies, medical decision-making. Is that something that we do at all times, even when the patients are hospitalized? Not really, because we go back to that provider that gets the call in the middle of the night, and we'll order pan culture or culture everything that you can see on my patient because it's late and I'm not going to do a full physical exam. I would much rather have the morning team deal with it. So it is very important for us to, as if you're a nurse or if you are any other healthcare provider, make sure that you have that assessment to rule out certain possibilities as the cause of that patient's fever. So head-to-toe assessment, extremely important if your patient has a fever. This is something that I show my students whenever I have students, whenever I'm presenting something similar to this, regarding what we do in the morning and what we do in the evening. So if you get the call in the middle of the night about your patient having a fever, obviously, if you're in the part of the morning shift, 7 a.m. to 7 p.m., you make sure that you have your bedside assessment, full physical exam, look at hemodynamics, oxygen requirement, look for lower extremity edema, auscultate your patient, do your neuro exam, stool output, look at the wounds, look at the joints, you do all that. If the patient has that fever, you don't really know where it's coming from, you order your initial CBC, CMP initial workup. If that is not necessarily giving you the information that you need, then you do a little bit more of a focus workflow with imaging, Dopplers, stool studies, blood cultures if needed. And then you get to your diagnosis of exclusion situation, which would be drug fevers, malignancy, autoimmune, etc. So that's what you do in the morning. In the evening, that should be no different. Like, you should get up and you should go and see your patient and basically go through the same process. It should not be different because you're covering nights. I know that it's not the best quality of life wise, but it needs to happen. That's the best. That's best care for our patients. So once we get through that whole clinical evaluation, we know that our providers are going to place some orders. And with orders, that probably could include blood cultures. This is when we get into the whole blood culture stewardship. There is a very interesting study called Distribute study that basically looked at a couple of different interventions and rules in order to order or to approve blood cultures. As you may know, only 5 to 10% of blood cultures will actually grow bacteria that is associated with the type of infection that we're dealing with or that we're suspecting. We know that whenever we allow our providers to very liberally order blood cultures, we will see an increased risk of false positive blood cultures, which may represent or may mean blood culture contamination, which goes hand by hand with longer hospital stays, increased antibiotic use, additional testing that might not be necessary, unnecessary removal of central venous catheters, portocats, higher hospital charges, or increased cost of hospitalization. I cannot tell you how many times I see patients being called back to the emergency department because their blood cultures are positive. Patients come back in, they get hospitalized, they get started on antibiotics, and then in a couple of days, they realize that all of that was for nothing because those blood cultures that were taken in the emergency department when the patient came in with a urinary tract infection were associated with a contaminant. So it happens quite often. And this particular study went through that process, implemented a workflow to make sure that we improve that practice. What this study basically recommended was for any new event of fever or any new event of suspicion of infection, blood cultures were not recommended in certain instances, which would include low probability of bacteremia. There are certain conditions that may not have a very high positive predictive value when it comes to blood cultures. Also, intermediate probability if the primary site is available for culture. Let's say that you have a patient that comes into the hospital with a fever, starting to look septic, and the patient has a cellulitis with an abscess in the leg. Obviously, if you're able to culture that, you may question, is it really worth for us getting blood cultures, knowing that the most common cause of cellulitis would be group A strep, and that one might be difficult to catch in blood cultures. So something to consider. Then for those patients that are not at risk for endovascular infection, or those that getting blood cultures was basically unlikely to change the patient's management, blood cultures were not recommended. The other indication for blood cultures was to document clearance. So the approved indications for that included Staph aureus, Staph lugdunensis bacteremia, all cases of infective endocarditis, because we need to make sure that the bacteremia clears, as well as whenever we're dealing with a central line bloodstream infection prior to line replacement, those are clear indications for blood cultures. If the patient did not meet any of those criteria, we could consider blood cultures if there was a single positive blood culture in a patient with a prosthetic device like a heart valve or if there was lack of source control of an infection and the patient was still clinically declining, we could consider getting blood cultures. So with this simple workflow intervention, it was seen that there was a significant decrease in blood culture utilization, down 18% for medical ICU units, and for medical units in general, down to 30% or so. So significant impact in the number of blood culture orders without compromising patient care. So very simple, again, very simple intervention to prevent blood culture orders, which would usually lead to inappropriate antibiotic orders that might not be necessary. So how can we reduce inappropriate blood cultures? Again, identify your risk, identify the patient's risk for true bacteremia. So if we think of certain medical conditions that are that have a very high positive predictive value for blood cultures, we know that low pretest probability for bacteremia would include an isolated fever, isolated leukocytosis on a patient that is in the hospital, because that could be basically anything, especially when we're dealing with a single temperature spike, non-severe cellulitis, lower UTI, non-severe community-acquired pneumonia, or post-surgical fever within the first 48 hours. In a way, you can see a fever, but there might not be a real big need for us to order blood cultures. So low pretest probability. Intermediate pretest probability for bacteremia, 10 to 50%, acute pyelonephritis, cholangitis, severe CAP. In these instances, I would probably consider blood cultures, even though my intermediate, even though the pretest probability may not be as high as those conditions with a higher pretest probability for bacteremia. So if you see a patient in the ICU with high suspicion for central line bloodstream associated infection, basically you rule out other possibilities for the fever, someone with discitis, vertebral osteoepidural abscess, endocarditis, those patients will likely have a positive blood culture, and those blood cultures are definitely indicated. So blood culture contamination, we know and that the expected number of blood culture contamination in most hospital facilities will be around 3%. So blood culture contamination should not exceed 3%. We know also that it's well known that contamination usually occurs from the skin, patient's skin, or the central line hub or the cannula that we're using to draw blood from. We know that when this happens, there will be an increased risk if we are drawing some blood cultures because the patient is not looking great. There is an excess cost of around $4,000 for patients that have contaminated blood cultures compared to those that have negative blood cultures. So I'm not at all saying or suggesting don't draw blood cultures at all. All I'm saying is that we need to work on optimizing that process, making sure that we have a good workflow for blood culture ordering, and to make sure that our phlebotomy staff and nursing staff have really good understanding of how important it is for us to make sure that the process is as clean as possible. We know that 40% of those individuals that have blood culture contamination will receive unnecessary antibiotics, which is a big problem for us big antimicrobial stewards. Some of those patients will receive prolonged therapy, an average of 7 days, but sometimes as long as 14 days, which may not be appropriate because that will increase risk for drug resistance, antibiotic side effects, C. diff, among other things. So once we kind of go over that whole ordering thing of blood cultures, we know that we need to minimize the risk of blood culture contamination. Then we will look into diagnostics. So diagnostics is very important when it comes to blood cultures. I don't really know what that slide is repeated 3 times, but it is very important. And there is newer technology. And I understand that not every single healthcare facility, not every single clinic will have access to certain technologies, maybe only larger hospitals. But I can tell you that if you don't have it yet, this probably will be the way of the future because of all the potential savings and patient safety that comes with implementation of some good technology that facilitates de-escalation of antibiotics. Not to necessarily, I promise that I'm not getting paid by BioFire. This is just one study, and I'm very familiar with this technology. So BioFire and film array is basically a PCR technology, a PCR marker that can be run on some blood culture bottles once they turn positive to rapidly identify what bacteria is growing in those plates. Routinely and historically, and maybe in smaller healthcare facilities, if we were to identify a bacteria in blood cultures, it may take sometimes up to 3 days to have all of that information of what bacteria we're dealing with, which means obviously a patient that was started on antibiotics has been receiving antibiotics for 3 days, when in fact, we could potentially know what bacteria we're dealing with within a couple of hours. So film array is that type of technology. And this particular study, they kind of went over retrospectively. They looked and analyzed some of this information when a total of 181 patients that received, and I hate to use the word inappropriate, I would say empiric, received empiric antimicrobial therapy. 33 of those individuals with positive blood cultures underwent that film array testing. The others went through standard of care, which was basically following up on cultures. And it was interesting to see that having that access to rapid diagnostic technology significantly reduced the time to appropriate antimicrobial therapy significantly, probably around 30 hours sooner than standard of care. So that is important not only for the purpose of patient care, but also for antimicrobial stewardship. We're minimizing the amount of time that the patient will be exposed to inappropriate antimicrobial therapy, narrowing down those antibiotics to make sure that we're actually curing that infection appropriately. Interestingly, also, they analyzed that 28-day mortality, and mortality was also significantly improved by narrowing down antibiotics to the most appropriate antibiotic for the type of infection. So having rapid diagnostic testing is not only significantly positive for the patient, but also for our antimicrobial stewardship efforts. So shorter duration of time to appropriate antimicrobial therapy significantly improved that 28-day mortality for those patients. This is kind of how it looks like, and this is just for gram positives. Whenever you have access to this type of technology, let's say your blood culture turns positive, you will find some PCR markers. They may say, you know what, you have a Staphylococcus species that is detected with a with a negative PCR for Staphylococcus aureus and a MIC-A gene that is detected. To me, that sounds like a coagulase negative Staphylococcus. And in the right clinical setting, we can easily say, you know what, that's a contaminant. Let's just stop antibiotics, monitor the patient, because the patient came in with a fractured leg, but someone decided to order blood cultures on admission and the patient does not look infected. On the other hand, certain facilities that have no access to this may end up saying, hey, there's a positive blood culture. Let's just keep the patient on antibiotics until we know what it is. And that may take 3, 4, up to 5 days. So de-escalating antimicrobial therapy as soon as possible is of significant impact to our patients. So in summary, blood culture stewardship, we want to make sure that we improve blood culture practices. Specimen collection, we want to make sure that we order 2 separate sites, use of really good antisepsis, consider the use of diversion devices to improve that clean catch procedure, providing ongoing education, not only to providers, but all staff that will be caring for lines. Central lines provide real-time feedback, as well as consider leveraging technology. We have rapid diagnostic testing, molecular diagnostics that will allow us to rapidly identify bacteria that might be detected on blood cultures, so we can narrow down antimicrobial therapy as soon as possible, not only with the purpose of decreasing cost, but most importantly, improving patient care. Also, As antimicrobial stewards, we also have the ability to work with the lab to, in a way, manipulate what antibiotics get reported when it comes to different bacteria. The purpose of that is to make sure that we provide options to providers that will make sense for the type of infection that we're dealing with. I cannot tell you how many times I have seen blood culture reports for Staphylococcus aureus that are reporting ciprofloxacin, levofloxacin susceptibilities, when in my mind, I would never use any of those for Staphylococcus aureus bacteremia. So what is the point of risking the patient by providing that information to the doctor or the nurse practitioner that may say, you know what, Cyprus reported here, let's just go ahead and use it for this infection and call it a day. That becomes a risk, not only like a legal risk for the hospital, for the micro lab, for the provider. So we can work with the lab to make sure that they're only reporting what they need to be reporting for the type of infection that we're dealing with. So in summary, what can we do to improve? We want to make sure that we work on that prolonged turnaround time for blood cultures. We can bring in potentially technology, if available, that can assist us to do that. We can decrease rates of blood culture contamination. Always look into that to make sure that we are improving patient care by minimizing the risk of inappropriate antimicrobial use. We can work on blood culture orders to make sure that only those patients that really need blood cultures get those orders in. We need to make sure that we educate providers, nurses regarding the definition of a fever. We want to make sure that if they're going to be ordering blood cultures, that they really know what the indication for those blood cultures will be. And also, we need to make sure that we decrease that limited patient examination. If your patient in the ICU who cannot give you any information is having a fever, make sure that you go to the bedside and make sure that you do a full assessment before you order diagnostic testing. So with this, once we hit all of those, we will definitely decrease that unnecessary antimicrobial use. And I think that would be almost my last slide. So take-home points, physical examination is key prior to ordering diagnostics. Diagnostic stewardship is important. Interventions to minimize blood culture contamination is also key to improve our antimicrobial use. Rapid diagnostics can assist in the escalation of antimicrobial therapy, as well as collaboration with the micro lab for reporting, making sure that they're only reporting what makes sense clinically. And that is it. I'm happy to answer any questions if I'm able to answer those questions. I'm not going to promise that I can, but I'm happy to take any questions.